Hello. Hi,
Hey,
Peter.
Peter. Hi.
Hello.
Hi.
Hello.
How are you?
Good. Thanks.
Okay, good.
Perfect. So we are now in the practice room. So we are not live yet. So this is a good time if you want to test your screen, for instance, share your presentation to make sure that everything is correct.
Yeah. Okay, do you want to do that or shall I quickly do it, Peter?
You can go ahead.
Okay, so let me do that. And share. Perfect. Okay. Does that look okay?
Yes, absolutely.
Perfect. Okay, good. Perfect. Okay, so I'm good.
Okay, perfect. Thank you.
I'll stop sharing. Good.
Let me try. Is it okay?
Yeah, perfect. Yeah.
Yeah.
Fantastic.
Okay.
Okay, good. So we're good to go.
Yes, absolutely. We have still a few minutes.
Quick toilet and then back ready for the meeting. Okay, then.
See you in a minute.
Okay,
All right, thank you.
I'll stay connected. Just
Yes, absolutely,
Okay.
absolutely.
Okay.
Okay. Hello, Bart.
Hello, Anna.
How are you?
My sound was off. Hello, Anna.
Hello,
Peter.
Hey, Bart. How are you?
I'm good. Thanks for being here. I thought this morning I didn't hear anything more from you guys. I didn't ask, but I hope you will all be there. But
thanks for the kind invitation.
I know. I think it's a great opportunity. Also, do you guys, Peter and Peter, have you met before, the two of you?
Yeah.
Oh, yeah. Okay.
I visited Cambridge in, I guess, 19.
Yeah. Okay.
And at that time we met.
Okay.
So Bart, we have already tested a few minutes ago with both Peters their presentations. So all is
okay.
good. And I think we will start with you, addressing the topic and introducing both speakers. And then you can remind the audience to post the questions in the Q&A box.
Yeah.
You can then pick the questions up from there and direct them to either of the Peters. And yeah.
Okay, that's great. So, hi, Peter.
Hello.
So how long should be the presentation?
I would say if you speak about 20 minutes.
Okay.
So we have 3 presentations, then that makes it an hour, and then there will probably be lots of questions and discussion, I guess. And the maximum I thought was 90 minutes, huh? Right.
There is no maximum, in fact.
Ah.
If the discussion goes well, there is no time limit at all. I would only suggest, because the webinar is being recorded. So normally we have a lot of restreams also later on in case someone cannot attend today. We put the recording to the EANS website and to our academy. So if it is short and nice, people rewatch it, you know, in a more efficient way. So
Yeah, that's good. Now we have a meeting of the trauma section at 6:30, so I think it's best not to go over that.
yeah, 90 minutes is just perfect, I think.
Yeah. No, that's good. So I will introduce both of you, and then the first speaker will be you, Peter Todd.
Okay.
And then Peter Smilewski, and then myself, and then I will try to moderate the questions. That's it. And we're all able to share our screen.
Yes, I've tried it. And
Yeah,
Peter
yeah.
Shall I give it a try as well?
Absolutely.
Does that work?
Yeah.
Yes,
Mhm.
perfect.
Perfect. Okay. I'll stop sharing now.
Okay, we have 4 more minutes.
Well, okay. It was a great meeting in Philadelphia. But I could only be there for part of it. I was a bit late due to surgery, and then I had to leave early, but I kind of enjoyed the concept.
So okay, so you voted for some part of it. You voted some bits. Did you manage to vote through the whole thing, or only partially?
Only partially. Yeah, because I had to leave. I actually had to leave when Marcel started his presentation.
Okay. So I'll let Sujin. I think either Sujin or Marcel been emailing the questionnaire to people that couldn't make it. So I'll ask them to email you so you can fill in the remaining bits.
Ah, yeah, okay. Oh, that's great. Yeah.
Oh, yeah, because that's important, because that forms the background of what what we will then summarize and take forward to the next meeting.
And when do you schedule the next one, Peter?
We haven't scheduled it yet. We need to see what we what material we have there, and then we'll email everyone with the summary. So that will be within a week time, the next few days, I think, possibly early next week. And then we also suggest another date. It needs to be far in advance, I suppose, for people to be able to to put it in the calendar, but not too far.
Okay.
Maybe in I don't know, another month or so, a couple of months. Maybe not, something like that. Yeah, because we want to the reason for this meeting is to write up something that collects the the thoughts and experiences of people that are using autoregulation in the clinical practice, in a way to follow up from what you've done with the Delphi exercise. But this is not a Delphi exercise. This is going directly to people that do use it, to sort of experts, and get their thoughts on how they use it. So it will nicely tie up with your publication, I think.
It's a really good idea.
Yeah, I thought so too. That's what my impression was when I was listening and filling the questions that I witnessed, that it was a good sequel to that Delphi. Yeah, indeed.
Precisely.
Okay, will you count, Anna? Or how does it?
Absolutely. I will let you know when we go live. We have another minute.
Peter ready.
Absolutely.
And with you.
Absolutely. And Bart, once I let you know, wait about maybe 30 seconds, because then people are connecting. So sometimes Zoom needs like 20, 30 seconds to kind of get people on to the session. Okay.
Okay, great.
I'm disappearing, but I'm here for the whole time.
Okay, perfect. Thank
So
you.
if we would mess up, you come and
I
help
will
us, right?
fix it. I will try to fix it. Absolutely.
Thank you, Anna.
Thanks.
Okay, it's 5. We are going live now.
Okay, dear colleagues and friends of the EANS, it's my pleasure to welcome you to this trauma section webinar on this Wednesday, 18th of January. And the topic of today will be autoregulation, the basics, the bench and the bedside. Autoregulation is a very relevant topic. It keeps being a hot topic. We all know for a very long time that there is no such thing in the ICU as a universal fixed target for blood pressure and for CPP. We've been experienced that for a long time, since the Houston trials, and people got aware that probably because of autoregulation being disturbed in a dynamic way, also the ideal zone of CPP is dynamic, but the question is how to determine that. And I have the pleasure to introduce to you here two giants in autoregulation research. The first being Peter Todt. Peter is a member of our trauma section panel and works as a neurosurgeon in Pécs in Hungary, and has done very nice basic research on the myogenic response and on the efficiency of autoregulation in elder animals. And I also want to introduce, and it's my big honor to do that, Professor Peter Smilewski, from the brain physics lab in Cambridge. The brain physics lab was really at the basis of developing clinical metrics for autoregulation monitoring. And so by doing that, they actually, made a huge step in making it possible to do clinical research on that. And Peter himself actually was the developer of ICM Plus, that is widely known, and also contributed a lot in the dissemination of autoregulation research. So first, Peter Todt will give a talk on the basics, then Peter Smilewski on signal processing and where we are in that and what the future will bring. And then myself, I am Bart de Preter. I work as a neurosurgeon in Leuven, also doing a little bit of trauma research. And I will add then a very humble part and a little part on where we are in the clinical practice and the application of autoregulation in that. So please first, Peter Todt, can you share your presentation? And you have the floor here.
First of all, thank you very much for the really kind invitation. It's really an honor to give this brief talk. Let me share my screen.
And while you're doing that, I would just mention to the participants, if you have any questions for both Peters and for myself, you can chat them in the question and answer box, and I will then moderate at the end of the webinar. Thank you.
Well, what briefly I would like to talk about today is the physiological and cellular level of the work what we've done in the recent years in autoregulation, and mostly dysfunction of autoregulatory function in various animal models, specifically here in brain trauma. And I'll show you some slides also about aging and hypertension, and we'll end on how these mechanisms might interact with each other. This is just the starting slide to appreciate the importance of the cerebral vasculature. just having a look at it, it's really easy to appreciate how important its health for normal brain function. So we have to start from the very basics. The brain is unique, and therefore the regulation of cerebral blood flow has to fulfill unique requirements, because brain has the highest energy consumption in the body, but it doesn't have any energy stores, and it's also closed in the skull, where the increases in volume is limited. So regulation of cerebral blood flow is the sum of integrated multi-linked mechanisms, and one of these mechanisms is the autoregulatory function in the brain. Just to make it easier to understand the physiological and pathophysiological consequences of autoregulatory dysfunction, I would like to start from this handbook picture. So not entirely true, but autoregulatory function makes cerebral blood flow more or less independent from changes in systemic and therefore perfusion pressure by adjusting cerebrovascular resistance to changes in pressure, therefore achieving a more or less constant or only linearly increasing blood flow. So to make it easier to understand why I'm going to talk about intrinsic vascular mechanisms and mechanisms of cerebral vessels, I just had to put this slide in, because autoregulation, based on the aforementioned, can be defined as changes in vascular resistance and or simply as changes in vessel diameter. So the observed autoregulatory function is mostly the consequence of intrinsic mechanisms of the vascular wall, namely the pressure-induced myogenic response of the cerebral resistance vessels, and also probably the flow-induced responses of the vessels. I don't have time to talk about flow-induced responses, but it would be really interesting to do so because it's still an open question whether we see constriction or dilation to flow in the brain. So just to also make it easier to understand the pathophysiological consequences of autoregulatory dysfunction, I have to start from this picture. So once the cerebral vessels step onto the brain surface, they form a PL network, and then small arteries and arterioles are diving into the brain parenchyma. Then they are divided into smaller arterioles than capillaries, and they are interconnected with astrocytes, interneurons, and at the capillary level also pericytes. So if the perfusion pressure goes up, the vessels, due to their myogenic response, constrict, therefore they increase their resistance. So this pressure cannot reach the downstream part of the cerebral microcirculation. So it's supposed to be protected from this hemodynamic stress. Just an example of this myogenic response. In an isolated vessel, you can see that we applied 80 millimeters of mercury, then a nice constriction developed in seconds. And this is a summary figure of myogenic responses of isolated cerebral vessels. You can appreciate that the so-called plateau phase is more or less overlapped with the autoregulatory range, what we can see in vivo. So if we focus on the upper part of the autoregulatory curve, what other researchers and ourselves observed in the past is that this autoregulatory function or myogenic response can be impaired in various diseased conditions, such like aging or TBI, and in other disorders, which means that when the pressure goes up, these vessels cannot effectively constrict in response to the pressure increase. Therefore, this high pressure reaches the microcirculation and disrupts it. So our question our basic question was whether this is due to the lack of a constrictor mechanism, or this is the consequence of an activation of a dilator mechanism. So first, we looked at traumatic brain injury because of its well-known epidemiological importance. Especially severe TBI has high mortality and affecting millions of people, both in the States and also in the European Union and worldwide, basically. And also because it is also known that autoregulatory dysfunction play a central role in the development of secondary injury of cerebral tissue after TBI through the formation of edema, intracranial hypertension, and as I just mentioned, pressure-induced myogenic constriction is supposed to protect the brain from the pressure increases. So in TBI, there is no protection. So we started from the literature, certainly, and also from our own research in peripheral vessels, where we showed previously that mitochondrial oxidative stress can contribute to vascular dysfunction. It's also known that TBI increases mitochondrial oxidative stress. So we tested our first hypothesis that after traumatic brain injury, TBI-induced mitochondrial oxidative stress may contribute to myogenic dysfunction. We used the widely known and used Marmaru model, the weight drop model, to induce severe brain trauma in rats, and then we isolated middle cerebral arteries of the rat and mounted the vessels in a pressure myograph system in which we can change perfusion pressure and observe and assess diameter responses of the vessels in response to pressure changes. What you can see on this slide is that contrary to the normal constriction, after 24 hours of brain trauma, these vessels cannot develop a normal myogenic constriction in response to pressure. But once we applied this mitotempo, which is a known mitochondrial antioxidant, this impaired myogenic constriction was restored to the normal level of the control animals. So this suggests that mitochondrial oxidative stress does play a role in this myogenic dysfunction. Well, just to figure out what is the agent exactly coming from the mitochondria, we used catalase, which is known to elaborate hydrogen peroxide, and we also added it into the vessel chamber. And what you can see on this figure is that myogenic response was also restored after incubating the vessels in catalase, suggesting that hydrogen peroxide is the agent coming from the mitochondria, which causing dilation or decreased pressure-induced constriction of these vessels. With another method, we visualized hydrogen peroxide production. You can appreciate here with the green fluorescence that hydrogen peroxide is overproduced after TBI, and this overproduction is effectively decreased by the addition of catalase. So the other question was whether, what is the target of hydrogen peroxide, which is coming from the mitochondria? What is the downstream effector in the decreased myogenic constriction? Calcium-activated potassium channels are widely known negative feedback regulators of the myogenic response, and they are redox sensitive. So they are sensitive to changes in the redox status of the cells. So we tested whether BK channels, the calcium-activated potassium channels, play a role in the observed myogenic dysfunction. So we activated its inhibitor, paxillin, and we saw the same restoration of the myogenic response of these vessels. We also induced hydrogen peroxide. We also applied hydrogen peroxide into dilation of the vessels. And what you can see on this figure is that hydrogen peroxide-induced dilation can be decreased by blocking BK channels, suggesting that hydrogen peroxide is acting on BK channels in cerebral vessels, causing decreased myogenic constriction. Supporting this idea, what we found is that both subunits of the BK channel are upregulated after traumatic brain injury in cerebral vessels. You can see that significant upregulation can be observed at both subunits. So the next question was whether other channel or channels are involved in the BK channel-induced decreased myogenic constriction, and we tested TRPV4 because it was also shown before that it's capable to activate BK channel. So we applied TRPV4 blocker, and we saw the same restored myogenic response after traumatic brain injury. So the impaired response was restored after application of the TRPV channel blocker drug. And the same, what I just showed you with the BK channel, we induced hydrogen peroxide dependent dilation of the vessels, and TRPV4 channel blocker was able to block this response. So these results suggested that mitochondria-derived hydrogen peroxide is causing decreased myogenic response of cerebral vessels after brain trauma via the activation of BK channels and TRPV4 channels. So the question remained, what is proximal in the order of BK channel, TRPV4 channel activation? Let me just skip this slide. So what that's where we were standing, that we already knew that hydrogen peroxide is the effector acting through these channels, but we didn't know how these how the function of these channels is connected. So we isolated cells from brain vessels of rats and ran patch clamp measurements. What you can appreciate here is that hydrogen peroxide is inducing BK channel current, and adding the TRPV4 channel blocker, this increase in the channel current is decreased back to the control level, suggesting that TRPV4 is proximal to BK channel. So hydrogen peroxide is probably activating TRPV4, and TRPV4 is activating BK channel. So we could conclude that in severe traumatic brain injury, at least in rats, there is an excessive production of mitochondrial hydrogen peroxide, which is activating TRPV4, which is activating BK channel, which leads to decreased myogenic constriction of the vessels. But still, the question remains whether it's activation of a dilator, lack of a constrictor mechanism, because it's still an open possibility in other pathological conditions. I have to go faster a little bit. So the second part of the presentation will be a bit faster. So we had a look at aging and hypertension, because hypertension is known and was shown to shift the autoregulatory curve to the right, which means that in chronic hypertension, hypertensive subjects are adapted to higher pressure values. So despite the higher pressure that these animals leave or humans leave, higher pressure will not lead to increased blood flow, because their autoregulatory curve is shifted to the right, so their resistance is increased. So we induced hypertension in both young and aged mice. You can see with angiotensin II, you can see that both blood pressure increased in the young group and the aged group as well. Then we assessed autoregulatory function with laser Doppler flowmetry. You can appreciate here is that this is the normal autoregulatory curve, and there is an extension of the autoregulatory curve in young animals, but this enhancement is lost in the aged ones. parallel with this in vivo findings, what we found in isolated vessels is that myogenic tone is increased in the young hypertensive animals, but this enhancement is totally lost in the aged animals. Along with this, vascular smooth muscle cell calcium content showed the same pattern. So it was increased at high pressure values in young animals, and it was absolutely lost in aged animals. We tested the role of 20-HT, which is a known player in the myogenic response, in this enhancement and its loss in aging. And what we saw is that the inhibition of 20-HT production, which is an arachidonic acid metabolite, the inhibition of 20-HT production decreased the augmented myogenic constriction in young animals, and it didn't have any effects in aged animals, and the same applied regarding the smooth muscle cell calcium content. So there was a 20-HT dependent increased constriction, and it was lost in aging. Same in smooth muscle cell calcium. These are the enzymes producing 20-HT, and we were also able to show that 20-HT producing enzymes are upregulated in young hypertensive animals, and this upregulation is not present in aged animals. We went through we tested the role of various channels. I don't want to go into details why we chose TRPC6, but we tested the role of TRPC6 channel in the mediation of 20-HT induced constriction, and we found similar pattern than inhibiting 20-HT. So adding TRPC6 blocker, we also were able to diminish the increased constriction of young animals, and the drug didn't have any effect in aged animals. The same applied to smooth muscle cell calcium content. And just showed you, just to show you the downstream consequences of the autoregulatory dysfunction, referring back to my starting slides, that lack of autoregulatory protection might lead to disruption of the microcirculation. We looked at blood-brain barrier function with sodium fluorescein, and what you can see here is that in young hypertensive animals, we don't see any extravasated sodium fluorescein, but in aged hypertensive animals, where we observe the lack of autoregulatory protection, we observed a significant extravasation of the drug, suggesting blood-brain barrier disruption. So in aging, there is no, in response to hypertension, there is no an adaptive enhancement in 20-HT production and TRPC channel activation, which will lead to penetration of the blood pressure to the microcirculation and ultimately blood-brain barrier disruption. So just in summary, I just demonstrated two different pathways leading to the same consequences. In aging and hypertension, together, there is a lack of adaptive enhancement of 20-HT action and TRPC channel activation, which will lead to decreased myogenic constriction due to a decreased activation of a constrictor pathway. In traumatic brain injury, contrary, due to mitochondrial hydrogen peroxide and so on, there is an overactivation of a dilator pathway, but it will also lead to the same attenuation of the myogenic constriction, and probably both will have the same consequences in the cerebral microcirculation, just like disruption of blood-brain barrier, microhemorrhages, edema, and so on. So the important question emerges here, how these pathways interact. First, whether they are present in humans, that's the first important question. And the other one is, how do they interact? Because it will determine how we can selectively target these pathways in patients who underwent TBI, and at the same time they are elder, or they have hypertension as well, which is also epidemiologically important, and so on. So this is this actually opens up more unknown than known questions. Just to show you an example, what I'm talking about is that we tested TBI-induced myogenic responses in hypertensive animals. And what we were seeing is that you can see here the TBI animals, the impaired myogenic constriction. This is the normal response of the control animals. This is the augmented myogenic constriction of hypertensive rats. And this is the also augmented response of hypertensive rats after TBI, suggesting that hypertension-induced enhancement of the myogenic response is not lost after TBI, suggesting, if I go back, that the constrictor mechanism, the enhancement of the constrictor mechanism, is able to block the overactivation of the dilator mechanism in a certain situation when all of these risk factors and TBI are present at the same time. Okay. Thanks for the attention, and I also would like to thank the members of my lab and also the funding agencies for supporting our research. Thank you.
Thank you very much, Peter. So I propose we go straight on to the next speaker, to Peter Smilewski, and we take the questions at the end. Then Peter, please.
Okay, fine. I'm going to share my screen now. Good. Perfect. Okay, Bart, thank you so much for your very kind introduction. So I'm going to take you through some more technical aspects related to monitoring of cerebral autoregulation and share with you some thoughts that I think, and some technical aspects I think that you need to be aware of while using this technology now. My disclosure, I do receive part of the licensing fees of the ICM+, and I'm partially funded by the EDRF European funding project for reversible dementia project that I'm leading. Okay, so cerebral autoregulation in traumatic brain injury, we theorize that the autoregulatory curves look a bit more like this. And like Peter has shown you just a moment ago, it might be completely like that. We can actually discuss that possibly later, the three of us, because I imagine that what we observe globally is a product of many local, perhaps, differences in the autoregulatory curve across the brain. So I think I'll start with this. There is a traditional way of thinking of autoregulation, classifying into a static and dynamic, where static is the response to longer term changes in blood pressure, and dynamic is what happens and how quickly the vasculature reacts to changes in blood pressure. And I would argue that unlike some train of thought where the dynamic autoregulation is in some way of assessing the static, I think it's the dynamic autoregulation that, particularly in traumatic brain injury, where things happen quite quickly at short scales, is more important. But in general, I don't see it as two different mechanisms. And it's a very nice review that looked at this and discussed this in some details, which essentially this is very a very intuitive, if a bit imprecise picture showing that the autoregulatory response changes smoothly, I suppose, with the speed of changes and the frequency of changes, becoming completely inactive with higher frequency, i.e. pulse, and regulating quite well at slow frequencies, possibly engaging different pathways. So let's start from the clinical question. What is the knowledge of the state of autoregulation useful in management of TBI? Well, for one thing, we know that if cerebral autoregulation is impaired, then any changes in cerebral perfusion pressure were likely to translate in changes in cerebral blood flow, and that may exacerbate the problem in traumatic brain injury, lead to ischemia, etc. But what I want to stress here, that a loss of autoregulation does not equate poor perfusion. It just means that there is a passive relationship between the two. The second thing is that intact autoregulation means that we can possibly control raised intracranial pressure with increases in blood pressure. And this was recognized in the guidelines and in particular in the recent consensus statement, where they advocated a MAP challenge to assess autoregulation in tier 2 to see whether changes in blood pressure could bring intracranial pressure further down. So how do we go about measuring autoregulation? Well, there's several different ways of doing it. The main thing to understand is that we have changes in blood pressure, that's the input, and then we need to measure the response of the vessels to that. And we can measure it either by looking at the flow or looking at flow surrogates like oxygen, or looking at blood, so what happens to blood volume, as in the case of intracranial pressure. And from there, we have, and other people generate a lot of indices of autoregulation that use these devices to try to track and monitor cerebral autoregulation. But what we have to understand is that each of these modalities, they come with different assumptions and underlying principles. So intracranial pressure relates to the volume changes. So what we see is the change in volume, not flow. When we look at near-infrared spectroscopy, we've got a flow surrogate with assumptions, additional assumption with regards to oxygenation distribution and concentration across arterial and venous parts. And we've got a volume surrogate when we look at the total hemoglobin. Same with the flow velocity. With PbTO2, it's slightly more complicated because there's also the oxygen diffusion part that is in the way. So if we go directly for assessment of cerebral autoregulation, i.e. regulation of blood flow due to changes to stabilize changes due to counteract variability in arterial blood pressure, we get techniques like transcranial Doppler ultrasonography. From there, we can assess autoregulation by looking at many different techniques, and a lot of work has been put in to this, particularly in the areas in population where transcranial Doppler is a default technique for assessment of vascular responses, like in stroke, for example. And this is one of the white papers from the Carnet group. Looks at and describes how to assess autoregulation using phase shift. There's also another simpler way of more perhaps intuitive, just looks at the response of flow to the pressure by looking at the correlation between the two, with passive being linearly related changes in blood pressure and flow velocity. But is this important for intracranial, for a neurocritical care scenario where we have patients staying there for a few days, and we want to know the state of autoregulation frequently, not just a point measurement? Well, with the advances in transcranial Doppler technology and the robotic probes, it is now possible to keep the transcranial Doppler recording for many hours. This is still far short of the several days recording as we can achieve with the other monitoring techniques, but we're getting there. And once we get there, possibly this is the technique of choice for assessment of cerebral regulation as such. While we don't have it, we have to go for other means that are available to us. And intracranial pressure is a little sensor, a way of looking into the cranium for us that is there by default, at least in modern neurocritical care units, and allow us to look at the changes in blood volume through this pressure volume curve, where changes in volume due to vascular engorgement or constriction leads to changes in intracranial pressure. And so we all know that there is this pressure reactivity index, which relates variability, spontaneous variability in blood pressure to variability in ICP, being the volume surrogate. When we see the changes going the opposite direction, we know that the vasculature reacts the way it should be. I constrict with high pressure and dilates with low pressure. And then there's a passive scenario when the autoregulation is not working, or rather vascular reactivity. So with this now, we can approach both of those questions that I spelled out earlier, the clinical questions. First of all, this is an example of a blood pressure, so perfusion pressure and intracranial pressure in a patient. And you can see that the cerebral perfusion pressure is at or above the critical level of CPP as stated by the guidelines. However, when we look at the autoregulation status, we can see that actually in this period, the autoregulation was already lost, which means any of these variabilities, even above the level of CPP threshold, will translate to a variability in flow. And of course, we also have the scenario here where we try to see if we can control this change in ICP with change in blood pressure. And yes, because the autoregulation works, that gives us confidence that changes in blood pressure will bring the ICP down as it is here. PRX has been shown to be associated well with outcome, even above the severity of the patient trauma and above ICP itself. But PRX has problems. First of all, it's not a volume but flow, which means that this is the flow picture, and you'll see here description more about this in the next talk. And this is the vascular size, the diameter of the vessels. You can see that the vessels keep dilating past the flow breakpoint. So that means that here PRX will still be okay, but the flow will be disrupted. So we have to bear that in mind. The second thing is that it relies on adequate transmission of volume change into intracranial pressure, and may not work very well, perhaps in circumstances where the compliance is high, like in the compressive craniectomy. However, there have been studies that shown that perhaps not all is that bad, that perhaps even in decompressive craniectomy, PRX still works, but the jury is still out for that. Second thing is that, or third thing, is that this index relies on the assumption that the variability in ICP is purely due to variability in blood pressure. It does not take into account other factors that may influence the variability of vessels diameter. And we know that this is not also true in general. In particular, there are artifacts from measurements, and there's a nice paper here from the group by Josef Skola from Czech Republic, where they shown clearly that artifacts in both ICP and blood pressure lead to invalidate PRX calculations. So these two things, these three things, actually to this scenario, PRX is 0, but is it 0 because there is a poor correlation, poor association between what we measure, ICP and blood pressure, or is it really because the autoregulation is well functioning? overall PRX a noisy parameter, and we can do a lot by smoothing the measurement, but this is not the ideal solution. And we know that there are problems in general with assessment of autoregulation. Some of it is due to physiological variability, as discussed by the Carnet group. And this is good because we have the continuous measure of autoregulation, and we want to see the variability to be able to assess other things that I'll be talking about a bit later. But also we know that the variability could be related to poor or low variability in blood pressure itself. So low variability in the input signal with all the noise coming in through the other factors means that the ICP may not be related very well to blood pressure. For example, this is a patient where at some point spontaneous oscillation occurred in arterial blood pressure, and you can see how PRX changes from the period where blood pressure variability was very low. It varies quite a bit compared to the period where these oscillations switch on. Now we can potentially help this by exercising an idea proposed by Ken Brady, who adapted a ventilator. Essentially, this is an experimental condition to provide modulated PEEP waves. And you can see, again, how PRX becomes stable when this PEEP waves are switched on. This is an experimental condition, but we also know that we can do that by using a psi mode, for example, some of the ventilators. This is work from Maastricht. Again, the psi mode was switched on, and you can see the variability here, and PRX becomes more stable. However, be aware that not all the variability is good variability. This is an example of oscillations of variability induced by the cubitus mattress. You can see that both ICP and blood pressure was affected here, causing these false increases in autoregulation. And this is where this effect were filtered PRX shows more stable recording. There are methods to deal with this. I'm not going to go too much into technical details, but it just essentially looks at the coherence of waves. It tries to sift out periods and areas of both in time and frequency where the relationship between blood pressure and ICP is not there. But in some cases, it's just not there. So removing periods with no variability, in this case, I mean removing the whole section. So we have been looking for other methods to overcome this. And you can see in this example, you've got blood pressure variability, no variability in ICP or very little, but there is variability in the amplitude of the pulse. And so if you can use that, this is a pulse, and that's just the Fourier representation, so the fundamental amplitude, which is how we calculate the pulse, but we could also do the peak-to-peak pulse. And if we just now substitute ICP with the pulse amplitude, then instead of PRX, we get an index called PAX, which behaves very similarly to PRX, but it's less sensitive to high compliance scenarios. Many indices have been tried and analyzed and looked at, and there is a paper that summarizes this if someone is interested. But the main message is these indices, although they do improve the relationship association with outcome somewhat, however, the increase in complexity and increase in the difficulties in, I suppose, in interpretation does not justify trying to push this in front of PRX, which has taken a long time for the confidence of the community to build up to use this index. So the simplicity in interpretation clearly wins still, until we can prove that there is definitely a better way of doing it. And if we have a possibility of using other measures that directly perhaps assess cerebral blood flow rather than volume, then we can use other indices I mentioned before. And again, in that paper, there's description and comparison. Now, this is an example of such an index. Near-infrared spectroscopy, it reflects, at least the RSU, the saturation of oxygen signal reflects blood flow, and the good thing is that you can put it on a probe on the patient's head and keep it for a long period of time, and it does behave like, often as we expect. But one has to be also aware of the limitations of it. In particular, its resolution. Resolution is tuned for clinical use of the variable as a saturation index, not as a measure of autoregulation. So perhaps looking at other measures from near-infrared spectroscopy, like the hemoglobin concentration, is a better way of using near-infrared spectroscopy for these purposes. Now, taking it further, what do we do with this information of autoregulation? Well, we can try to individualize the CPP threshold, going away from the fixed recommendation. And you are all aware of this concept, where there is, if you plot autoregulation or PRX versus CPP, there's a sweet spot that show optimal CPP at some point. And that sort of shows the middle of the autoregulatory curve. And in our software, we have implemented it, and we have shown that one could see the sweet point in patients, and we can actually calculate it in real time. Each point will take several hours of calculation to produce this value. And so with that, we were able to show that treating the patients close to this value is better for patients, both in terms of mortality and severity. We then proceeded to do the Cogitate study, which assessed the feasibility and safety. In this study, we had two groups. One group, a control group with no information about autoregulation displayed, and one with the autoregulation displayed, and with the specific target suggested to clinicians. And that study, described in the paper above, has shown that this way of individualizing CPP-op is feasible and it's safe. However, before we can go to the next phase and level 3 and phase 3 trial, we have to consider some things, in particular this effect here. There are two different scenarios of curves. In one side, this is PRX, this is CPP. In this curve is flat, autoregulation is largely lost throughout. In this curve, it's lost at the extreme, but it's very well preserved in the center. So if we're treating the patient at this point, here we are close to the CPP-op, and yet autoregulation is not preserved. Here we are further away, and we can actually improve the patient by targeting CPP-op. So if we just go after the target, these two situations will be lost, and we will not be able to differentiate whether we actually benefiting the patient with this approach or not. So the way to do it, perhaps, is to track the low and high, the upper and lower limit of autoregulation, and or use the whole curve to assess. And finally, when we go further to a trial, we might also consider actually creating a protocol that includes other modalities into this, because just using one modality is a very difficult proposition to choose to prove that it actually improves significantly outcome. And we've got examples from the PBTO2 trials. This is just one of the protocols possible that we've been proposed here in Cambridge that looks at both PBTO2 and PRX together. Finally, I just want to mention that this technology is not only available to the ICO Plus users, it starts also appearing in other in other manufactured devices. But be aware that going after one number that the algorithm, the monitor, gives you is not the best way forward. If you see here in this graph, actually there really isn't a suggested optimal curve, despite the value being proposed. So one has to be aware of this. There are many parameters that go into the algorithm itself, And so they need to be fine-tuned. So look at the curve if you've got the possibility of doing that, of PRX versus CPP, not the actual number at this point yet. What comes next? Methodological improvement work, finding the determinants of impaired autoregulation. Peter Todd is a person that will help us with this, and there's a phase 3 trial. Messages to take home. Can we monitor autoregulation at the bedside? Yes, there are different methods. None is perfect, but one has to understand what they do and the assumptions and the pitfalls. PRX of all is the most validated in traumatic brain injury as a continuous monitor, but other possibilities are there. And as far as this individual CPP target, the method is safe and it's feasible. However, estimation of the actual CPP target is not trivial. And so blindly following a target value is not, again, the way forward. And this is my acknowledgement. Lots of people have contributed to this work, and I would like to thank all the contributors. Thank you.
Thank you very much, Peter. I see no questions yet, but I will proceed with my talk then, and then I'm sure questions will come. Share my screen. Okay, you should be able to see my screen now.
Yep.
Let me just hide this. Okay, good. So, so I will talk a little bit about research we did in Leuven to put things a bit into perspective from my side, and then talk in the second part of the talk about where are we now in clinical practice and where should we be going. These are my disclosures. So, well, I will not really go into this, but we should be aware that cerebral blood flow, the regulation of it's really complex, and there's several systems involved in it, even systemic ones. So what we're talking about here is really about the myogenic response driven by intraluminal pressure, which we tend to call autoregulation. And a couple of years ago, that was in 2015, we set out with a research project where we wanted to establish an animal model with a cranial window, basically to first validate PRX in it, and then to use that to quantify, let's say, confounders of autoregulation that should enable us to do better clinical studies and to stratify patient studies in a better way, to avoid that a trial on autoregulation would be so many negative trial as we have in many negative trials in TBI. So that is what we embarked on, and I will quickly show what we found so far, and it does shed light on some things. So we used a piglet model as a large animal equipped with a cranial window, through which we can, with a microscope, observe the diameter of the pile arterioles. We can only look at the surface, obviously. And by labeling red blood cells, we can measure the speed of the red blood cells. And hence, when we have the velocity and the diameter, we can calculate the flow. And a calculated flow, you will see that through the rest of the presentation, we call a flux. And in the animal model, we can also instrument it with equipment that is usually used in the ICU, like ICP, PBO2, etc., etc. And we can calculate from that PRX, for instance. We also used laser Doppler flow to validate that the calculated flux was actually meaningful. And here you will see a small movie. So you see on the left-hand side the microscope over the cranial window, and you see from the left to the right an artery in which you very quickly see the traces of the red blood cells. And there's also a vessel with much slower red blood cells. That's obviously a vein. And so in addition to that, we implant a balloon either in the aorta or in the caval vein. And when we gradually inflate that, we can mechanically influence the blood pressure, gradually increase it or gradually decrease it. So an experiment would look like this. In the bottom, we would induce the animal, then do all the surgical manipulations, then let it recover and stabilize. Then we would inject the labeled red blood cells and then start with the blood pressure manipulation and see what happens with the diameters and the speed of the red blood cells. You can see that here, for instance, when we lower the blood pressure on the right-hand side, you can quite clearly see that the diameter of the arterioles increases. So by gradually decreasing blood pressure on the left-hand side, when we then plot the flux or the laser Doppler flow against CPP, you can see still on the left-hand side a stable zone of CBF, but also quite neat, clear point, the limit, the lower limit of autoregulation, where CBF will drop beyond that point. When we gradually increase the blood pressure on the right-hand side, you basically see the same when you plot the flux and flow against CPP, but there you see that it's a more gradual increase in flow, and the limit, so there's a stable zone obviously on the right side, but when you go to 100 and beyond that, there's a very gradual increase in CBF. We can do some statistics on that, do breakpoint analyses to try to statistically identify the lower and upper limits. And this is basically what I wanted to show you. By doing that, we find when we pool all the data of all the several experiments in the different animals, we can find a lower limit that is actually quite clear in all the data. But as already said, when we gradually increase the blood pressure, there's a gradual increase in CBF beyond a more narrow plateau, and so it's hard to determine in that gradual bend of CBF where actually that upper limit then is. So we wanted to understand that a bit better and looked at arterioles of different sizes. And what we then found is then when you start with the baseline CPP and you lower the blood pressure, you see that the smallest arterioles that actually are the majority that are in there, so the capacitance, they contribute most to the capacitance of the vessels. So there will be a dilation that will be most pronounced in the smallest arterioles. On the other hand, when you increase the blood pressure, you will see that the smallest arterioles actually cannot constrict that much more, and then very quickly they give up and they are blown open because they have a smaller amount of smooth muscle cells, whereas the arterioles that are a bit larger in size can even go a little bit further with vasoconstriction, and then the point where they are passively blown open is further down the CPP axis. And so putting everything together in the pooled data, you see then that the CA curve looks like this. You have that more narrow plateau, which is basically almost entirely situated to the left side of the baseline CPP. So in the green, you see the diameter of the vessels. You see a dilation when you go down with blood pressure. So that causes the plateau in CBF to the point, the lower limit of autoregulation, where then CBF will drop. When you raise the CPP, you will see that the CBF will remain kind of stable for a certain while, but then it will go up, and that will be quite gradual. And the point where it starts going up actually comes quite early. So two consequences of that. When you confront that, for instance, with PRX, with a clinical metric of PRX, and the PRX is shown here in yellow, PRX is able to pick up the lower limit that is determined by the breakpoint analysis actually very well. But if we go to the upper limits, and this is quite artificial, you would say, and it actually is, by breakpoint analysis, we can determine several upper limits. Here we did 2. And so PRX finds it a bit harder to determine these. And this is obviously due to the fact that the plateau actually stops there and you get a gradual increase. And so the upper limit is not that sharp, really. And so this is reflected here as well in the area under the curve. That is quite good, 0.77 in these experiments for the lower limit, and it goes down if you look at the upper limits. Another thing that we observed in there, and that's associated with that, is that there's between the animals a huge variability in the lower limit and the upper limits, as you see here. And so when we want to develop a monitoring device, it should not necessarily work on pooled data. It should actually work in each individual animal. And so you can see then here, and this is just an exercise that in individual animals, sometimes PRX is very well able to predict the lower limits and sometimes also these upper limits, but sometimes also not. So that's consequence number one. Consequence number two is, and I just very quickly go back to this graph. So as said, the most of the plateau is on the left side of the baseline CPP. So you would say from this that it seems that autoregulation mainly protects against lower blood pressure and not so much against higher blood pressure. So is that true, and can we find evidence for that in literature? And this is what I would talk about in the next few slides. So do we have evidence on the existence of brain damage associated with mild arterial hypertension and of the mechanism behind that in intact autoregulation? And so, yes, there is some evidence. And here, this is a difficult slide, but I will try to quickly explain it. On the left-hand side in both graphs, you see a relation that is plotted by color code between outcome and events of CPP. On the x-axis, you have the intensity of the event, and on the y-axis, you have the duration on it. And on the left-hand side is the tolerance for or the relation between insults of low CPP and outcome, and on the right-hand side for high CPP and outcome. You can actually see that the line that reflects no relation between the event and outcome, is the black line, is actually very clear, very well demarcated between the blue zone, which is a positive relation, and the red zone, which is a negative relation with outcome. So you can see here the tolerability for insults for low CPP and on the other side for high CPP. And if you plot these two together, you get a triangle, which is the blue one here, and you see that it's not indeterminate in time, so it's limited in time, and that's obviously because this is data from TBI patients. They have dynamically impaired autoregulation, and so the safe area of CPP obviously shifts in time. But now, and that's what I wanted to talk, what I want to tell in this about this slide. When we only consider the events with a deficient autoregulation here, that's the red curve, you see that obviously the triangle becomes smaller. When we only consider the events with an intact autoregulation, and that's the green one, the area becomes much wider, and you do see that between 60 and 70 millimeters of mercury, there's like a safe zone that lasts for much longer. Now, the point is that what you see is that autoregulation, intact or deficient autoregulation, affects the tolerability for low CPP and not for high CPP, which is in line with what I just said about autoregulation seems to mainly protect against low CPP. This is evidence from a totally different perspective. There's many trials and also systematic reviews that looked into how arterial hypertension is associated with cognitive impairment and dementia in later life. And there's clearly an association already in older patients between blood pressure and this risk. And this is true over the entire range of blood pressures, because autoregulation, as Peter has already told, is deficient in older people, and so also low blood pressure is associated with a risk, as is high blood pressure. But in midlife people, let's say regular adults, a low blood pressure because of intact autoregulation is not associated with a risk, but a high blood pressure actually is. And the mechanisms behind it is very clearly described by several papers in literature. It's neuroinflammation due to microglia activation and blood-brain barrier breakdown. And I will quote a study that was already cited by Peter as well, and done by him, where he compared younger and older mice and the effect of increased blood pressure there. And I will give a little tweak to the interpretation of it, or at least it's from this perspective now that I look at it. Also in the younger mice with arterial hypertension, and it was not so much pronounced, but there was also some degree of blood barrier breakdown and microglial activation. But this was much more pronounced in the older animals with totally deficient autoregulation. So meaning that there is some damage already in younger mice with arterial hypertension. And so long-standing arterial hypertension is not necessarily well tolerated. So it's not protected against necessarily by autoregulation. And the fact that the older animals with deficient autoregulation have an exaggerated damage means that it's not so much the intraluminal pressure itself, but it's the increased CBF that drives the damage, because the deficient autoregulation there will increase the CBF even more. So there's several points of evidence that actually support this, that autoregulation mainly protects against lower blood pressures. Let me then switch to a totally different perspective, the clinical perspective. A couple of years ago, we did a Delphi consensus study amongst clinicians, and you will recognize some people here in this list, like Dino Stocchetti, David Adelson, Giuseppe Citerio, Randy Chestnut, etc. And that was when we did the ICP 2019 meeting in Leuven. It was associated with that. And so we wanted experts that had expertise in clinical management of patients, that did active research on that and had publications, or at least had an academic appointment, could be neurosurgeons, neuroanesthetists, or neurointensivists. And we did not want more than expert per department, not to have too much influence from certain schools. So the expertise should be, let's say, heterogeneous. And so we finally invited 31 people by those criteria, and 25 collaborated throughout the different rounds of the Delphi. We had 65 statements and 12 multiple choice questions, and consensus was defined as obtaining more than 75% of agreement. And so we had several rounds to try to enhance agreement. And you see here that we got to the point where we had 25 statements on which there was consensus. And there was also agreement on 5 statements that there was no consensus in these statements, and I will walk you through. So first of all, there was consensus on these statements. Autoregulation covers several mechanisms, and that mainly reflects that the lower and the upper limits not necessarily may have or may reflect the same mechanisms. So aiming at adequate nutrient supply to the brain. Impairment of autoregulation is not binary, but it's a process that results in dynamic narrowing, so it can differ throughout time. A CPP below 50 should not be accepted. Also, high CPP has side effects. Intensity and duration, so not just intensity, but also duration of low CPP insults are associated with outcome, and the same is true for high CPP. But episodes of low CPP are more detrimental than episodes of high CPP. Absolute and universal CPP targets do not exist, and the best CPP target zone depends on the autoregulation status, but probably also on other variables. And these are the statements on which there was no consensus, and all experts agreed that we should express that there was no consensus on that. So there's no consensus on the best manner on how information on CA status should be used in clinical practice. Also, there was no consensus regarding the accuracy, the reproducibility, and the validity of any autoregulation assessment method for clinical practice. And there was also at that time no consensus on the safety of implementing a protocol based on autoregulation in clinical practice. Meanwhile, we have had a Cogitate trial that's actually showed that it is feasible and it is safe also to implement that. These are a couple of other statements on which there was consensus. Microdialysis output is probably not the best measure to use in a autoregulation metric because of the very low frequency of that, obviously. The current methods are probably insufficiently understood, and they produce different information. So if you compare different metrics, they tell different things. Information on autoregulation may be helpful, but is subordinate to ICP, CPP, and PbO2. Impaired autoregulation worsens the tolerability for high ICP, for low PbO2, and probably it worsens the tolerability overall for any secondary insult. And whether or not the CA status is intact or deficient, that has an independent association with outcome. And then finally, and I'll be quickly on this slide, these were statements on research. So the priority for research is high, all the experts agreed on. What was said is that when a new method is developed, it should be validated against a method that includes quantitative CBF analysis in the equation, either in animal research, in the lab, or in patients. Now, having said that, at the same time, the research should move to patient studies based on PRX and CPP, because these tools exist and are most validated, as Peter already said, and so we should use that to the best extent possible. So the main points in the discussion of that whole Delphi process were the following. Autoregulation is dynamically impaired, so the safe CPP zone is dynamic and changes in a dynamic way, but that happens within a certain playground, and also that playground has limits. And it was said that the lower limit of that playground definitely is 50 millimeters of mercury. Probably the CA buffer is a nonlinear one, and there's hysteresis involved, so the lower and upper limits do not behave in the same way, and also there is some dependency on the direction in which you are moving. There's a validation deficit of currently proposed metrics when you confront them with animal research, and this is mainly based on the fact that things are not understood to the maximum way yet. And there's a lack of sufficient prospective patient studies, and I'll come back to that, but it is still very promising. That was definitely also a point to make, and so it was decided to really put forward that research should be done in a parallel two-track way. We should invest in basic research, but we should also invest in prospective patient trials based on the clinical metrics that are available. Now, what about current management at this point? And also the paper, the Delphi paper discussed that. So the safe CPP zone being dynamic, CPP should not drop below 50. We already said that. PbO2 is a helpful metabolic parameter that helps us detecting insults of inadequate nutrient supply in spite, not in spite, but in spite of the ICP and CPP being okay. It's good always to review trends of ICP and ABP. So don't just look at a number, but review trends, and that gives you a rough estimation of CA over a longer period, and that's probably the best to do. And this information may be helpful to reduce ICP by increasing CPP in case of intact autoregulation. When ICP is too high and you know that autoregulation is intact, the best measure probably to take is increasing CPP, and that's also reflected in the CIBIC algorithms. And it was discussed, and the conclusion remained that autoregulation information is very useful and helpful and probably very important, but at this point, it's still subordinate to ICP, blood pressure, CPP, and PbO2. So I quickly refer to the CIBIC algorithms, as already Peter did. There are different scenarios based on ICP and PbO2 monitoring. ICP can be too high or PbO2 can be too low, or you can have a combination of both. And in tier 2 of those B, C, and D scenarios, it is stated that looking at autoregulation is a good thing because when autoregulation is deficient and your ICP is high, increasing blood pressure may further increase ICP. On the other hand, when autoregulation seems to be intact, it's probably a good measure to increase blood pressure and CPP in order to reduce ICP. And also when PbO2 is too low, the same is true. When autoregulation is intact, the CPP will be a very good driver of an increase in PbO2. Plus, still in addition to that, and that's a quote of Randy Chestnut, when you appreciate that a patient has an active autoregulation, this patient is probably in a healthier state and can take more insults. The tolerability for insults will be higher by definition. So where do we stand? And it's a very short conclusion, but it just summarizes where we stand. appreciation of active autoregulation is probably very helpful already in current protocols, because it tells you that your patient is in a healthier state, and you have the possibility of ICP reduction and also of PbO2 increase by increasing blood pressure. Basic research should go on. There's still many things to discover about autoregulation and how it works. But at the same time, we need more prospective patient trials on clinical metrics. And having said that, Peter talked about phase 3 trials, and the Cogitate trial on safety and feasibility has been published, and it has been shown in there that it is feasible, and it's particularly also safe to include autoregulation metrics in clinical practice. My list of collaborators is not that huge, but I sincerely want to thank them, because they're great people that helped our projects a lot. And so by that, I want to thank you for your attention, and will stop sharing my screen. There seems to be one question. No, I cannot.
There was one question that I answered about analyzing
entropy
of ICP. So just to repeat what I said in the entropy measures and any sort of and complexity measures in general, they look at the superposition of many autoregulatory mechanisms in the brain and systemic altogether. And yes, indeed, if you see the entropy of ICP going down, it's a sign of physiological derangement at some stage. We don't know exactly what causes it, and which bits of physiology is responsible for that. So it's a useful extra parameter to monitor, but not directly related to cerebral autoregulation.
Thank you. While there may be more questions coming, I want to ask a question myself to Peter Toth. Peter, you showed that in TBI, and you showed the pathway behind that. The way you actually demonstrated how autoregulation is impaired is by a lack of constriction, a deficiency in the vasoconstriction of the vessels. Now, would that also work the other way around? You could potentially come to different conclusions when you look at the vasodilation when lowering the pressure?
Well, maybe you mentioned it, or maybe Peter. I cannot recall that, but I'm convinced that dilation to decreases in pressure is a totally different mechanism than responses to increases in pressure, and it may also involve the endothelium. So it's, at least as I can recall, that it's not entirely clear whether it's only a smooth muscle function or endothelial function as well. Dilation to decreasing pressure, and certainly activation of the mentioned players can be involved in the dilatory response, but as I just said, it's a totally different issue. What if I can, I have a comment actually to your presentation, if you have time for that.
Before the comment, can I comment or ask a question with regards to the specific thing that we just discussed?
Yeah, sure.
It's a difference between the reactivity of the vessels to the to lower blood pressure versus high blood pressure. So as you showed, to summarize, you showed but that, or you postulate that the brain has better ability to regulate for dropping blood pressure, so hypotension rather than hypertension. But interestingly, work from the Carnet group that look at the dynamic responses of blood flow to changes in pressure going up or going down, what they seem to see is that the brain, the vasculature seems to be faster responding to hypertension, so higher blood pressure, so the high blood pressure challenge, rather than the dropping blood pressure, postulate or hypothesizing that physiologically this makes sense because it takes longer for the ischemia to occur than for the brain-blood barrier to be disrupted. So this is an interesting thing that it's on one hand, it's the speed of response might be higher for high pressures, but overall control may be lower. So I mean, it's both to Peter and Bart a question. Can you share us some thoughts? Share with us some thoughts on that.
Bart, please.
Yes, well, the thing is that we're all looking at that with different models that like seem to highlight something something more than something else probably. So that's probably what it is. So when you start looking at it, it's very hard to look at the complete picture. We try to do that in the large animal model and just observing physiology and not working with drugs, etc. But the moment you start interfering, the moment you start manipulating something, you actually already influence what you want to observe. And that's so the difficult thing is how to put all these pieces of information together. And yeah, that's a very vague answer, obviously, but that's the difficulty here.
Actually, this is what I wanted to point out, more or less, in my comment, that we cannot forget what I just showed in the third or fourth slide of mine, that there are two hemodynamic forces acting on the wall. So pressure, but flow as well, both shear stress as well.
Yeah.
And certainly as pressure changes, flow changes as well. And it's acting on the wall. And it must be regulated also in a negative feedback manner in the brain. Otherwise, it would lead to an uncontrolled dilation of the vessels. And actually what Bart showed, that at a constant diameter, they saw an increasing blood flow, and they cannot really see an upper limit of autoregulation. Probably it makes it understandable that if you have a constant diameter but increasing pressure, you will have an increasing flow, right? So what about then the flow-induced response of these vessels? And actually that led to the hypothesis of ours and others as well, that flow-induced responses may be different in the brain than in the periphery, because exactly for that, to have an intact upper limit of the autoregulation, we need another constrictor mechanism than pressure-induced constriction, and it might be the flow-induced constriction of the vessels, which would add more constriction, more increase in vascular resistance. Thus, the decreasing diameter would be able to maintain a more or less stable blood flow, not an increasing blood flow. And the thing is that it varies from species to species. And actually, in pig, what they found in isolated vessels, when the pressure was kept constant, but flow rates was changed with a constant mean pressure, that the vessels responded flow rate dependently. So at low flow rates, they constricted, but at higher flow rates, they dilated. So actually in pig, when you have higher pressures, in addition to the myogenic response, these vessels might respond with dilation. Therefore, you cannot really see in pig, in vivo, the expected autoregulatory response at the lower pressure range. But in other species, for example, in rat, we saw in our pressure myograph that the vessels constricted to flow independently from the flow rate. So they constricted to low flow rates and high flow rates as well. And exactly the species variability, what you just mentioned, the model and species variability. We also isolated human cerebral arteries and arterioles, and we assessed their flow-induced responses, and we also saw flow-induced constriction. So at least this suggests that there might be different autoregulatory mechanisms in different species, and I guess we should look at those models, which are similar to human responses. This is one thing. The other thing is that to keep in mind the shear stress-induced responses of cerebral vessels in terms of autoregulatory function, and for future studies, just to keep it in mind, because it's a totally unsettled area of research.
And another difference, I suppose, was that in your case, Bart, you are looking at, I think, slower responses in autoregulation than in those studies by the Carnet group, which they use the impulse response step challenge, etc. So perhaps there is also that. So that leads me to another point, Peter, to you, whether you can see a time-dependent difference in response of different modulators in the vessels. I mean, with some acting immediately and some kicking in a bit later.
Well, I cannot recall that graph, what we just also included in that paper to which Bart referred. But we also assessed the dynamics more or less as we could, the dynamic responses of the vessels. So we added sudden pressure step on the vessel and measured the time and certainly the magnitude of the constriction, how they reacted. And as I can recall, it was also impaired in aged animals and also in hypertensive animals. So they were much slower to respond than the control ones.
But have you seen different pathways for?
We didn't address this.
Okay.
It would be really interesting, but we didn't address this.
Fantastic. And another thing. Well, okay. I'll let you, because it's unrelated to this question. So, Peter, you were going to comment something, and I interrupted you rudely.
No. That was actually my comment. I wanted to comment on Bart's graph, where he nicely showed that at a constant diameter, flow was increasing. And I just wanted to say that exactly this consideration led us to propose the possible existence of flow-induced constriction in the brain. That there might be another constrictor mechanism which makes autoregulatory function effective.
Definitely very interesting. We have a couple of more minutes, and there are actually two questions from Akos Koller, I see. Are there any new type of treatments for TBI, and how can you control brain edema? Edema, I mean. Are there any new types of treatment? Peter Todd, maybe?
Well, as far as I can recall, not like I mean, mechanistically targeted treatment. There's no mechanistically targeted treatment to restore autoregulatory function. I guess that would be the brief answer of mine. At least that I mean, what Peter was talking about, the optimizing perfusion pressure and so on. It might be a way, but no targeted pharmaceutical or other mediator-driven treatment available now.
Yeah, I would answer the same in that, and we're not completely there yet, and it's not entirely new either, but it's in the physiology, I would say, and it's in the precision medicine behind it. So what we should try, and that's actually what we try to do with our research, is to try to identify pathophysiological processes rather than just simple pressures or simple monitorable values. It's about events, and so once we get a bit closer to identifying these, we'll be able to help our patients better. I think that's where we are heading to, and hopefully we will make further progress in that.
Or answering it in a different way, that would be wonderful to specifically target overactivated BK channels in humans, but we don't know yet whether it's overactivated in humans, and we cannot specifically target those channels yet. So,
yeah, and probably the same accounts for controlling brain edema. There is no, well, definitely no pharmaceutical treatment for it. It's as still as what we learned from the BTF guidelines, for instance. You have to try to control ICP, but there's no targeted drug. Are you currently using PRX in making clinical decisions in your practice? How do you do that in Cambridge?
Well, each consultant in Cambridge has more or less their own fine-tuned way of doing things. So we don't have a specific protocol that is accepted by the whole team. They are, as I showed, there is a proposal for a protocol for combining PRX with other multimodality monitoring, including PbTO2 and microdialysis, to try to differentiate between loss of autoregulation due to inadequate perfusion drive and due to mitochondrial dysfunction. And so you then test for different, you look at different measures and you try by following the reasoning, the tree reasoning, decipher one or the other. But in general, what happens is that the clinicians would look at the at PRX trend. We'll look at the curve, the relationship between PRX and CPP, see if that convincingly shows particular pattern of behavior, and then they would also take into account other aspects of the clinical presentation, and then make decision based on that. It's not just going after one single parameter, as I said in my talk.
That's, I think, an important message. Peter, you want to add something to that?
No.
As a final word? No. Well, I will use my privilege as moderator then to close the webinar here. I want to thank both of you, both Peters, for being such wonderful speakers. We should repeat that, or we should talk more. That's what I learned from this webinar. So thank you so much, and thank you participants for being there and for your attention.
Thank you.
Bye-bye.
Thank you. Thank you so much.
Bye-bye.
Bye-bye.